So means to say that no one thing will be an answer for anything. So you have to choose whatever is relevant and useful for each and individual patient. So I am not here to advocate whether you have to do only a primary vitrectomy for retinal detachment or not. But in case once you have decided that you are going to do a primary vitrectomy instead of going for a scleral buckle, what and how to do and what are the advantages of putting a belt and not putting a belt, especially with sutureless surgeries coming up right now. And to tell you frankly, I do scleral buckles, I do sutureless vitrectomies, and I do surgeries with a belt. It's not that I do only one. I do all three based on whatever is needed for that case at that time. And many times I might start doing a case where I wanted to put a belt, I open everything and then decide that no, I can't put it, I might convert only to a primary vitrectomy. And times where I start with, say I don't want to put a belt, while doing surgery I decided that no, I need a support, so I might do a belt in the middle. So it's a dynamic process. You have to keep thinking when you're doing surgery. It's not that you decide one thing and go ahead and do everything, whatever. So let's see what it is. So as Srinivas was talking about, there are multiple options like pneumatic retinopexy, scleral buckle and vitreous surgery, and you decide which one you want to choose. So this is what was we were seeing to make a buccal loop and pass it through it, so it becomes easier for you to, instead of passing the sutures there. Not easy always. Sometimes you have a thinner scleral flap and you might have a thicker scleral flap, you might have a perforation. So these are all the complications you come with. So why do you need to do this? It's basically managing the peripheral vitreous. So when you have decided to remove the vitreous, and why do you want to put a belt? So might as well do a buckle? No. So whenever you are not sure about your peripheral vitreous, what is it going to cause? Whether it is going to cause contraction over a period of time and causing a retina to redetach. So all these efforts are basically to prevent a redetachment. So we need to see why and how these are helping. So if by putting a belt around the eye, you are trying to compress the eye so that the contraction effect of the vitreous base is reduced, not completely lost. Because this is another way of dealing with the same thing. So we are actually trying to remove off the vitreous and shave it close to the break and remove off the whole vitreous base to the extent possible, because you cannot completely remove the vitreous base, so that the chances of that causing a contraction and causing a retinal break to open or causing a new breaks become less. So these are two different ways of managing the vitreous base. So when we say that belt or no belt, this is what we are actually dealing with. So it's not something else. So let's look at how does a primary vitrectomy with or without belt or fade. So the studies which have shown that yes, if you do a scleral buckle or do a primary vitrectomy, sutureless vitrectomy, the results are almost similar. That doesn't mean that you have to do primary vitrectomy for all patients, because there are some complications, as we were talking about, having a cataract or having difficulty in managing while doing surgeries and all those things. So an endophthalmitis is a definite risk factor when you go inside the eye. So what are the problems which we face in each procedure? So when you put a belt, it's more an extensive surgery. You're going to dissect the conjunctiva. You will have post-operatively chemosis. Patient will have, many times I have seen patients coming with too much of a chemosis and complaining that no, I have pain. And let's say it takes a little longer time when compared to scleral buckle, maybe 10-15 minutes more, but it's definitely more than doing a primary vitrectomy. And I said, problems with conjunctiva. You open a conjunctiva all throughout. If suppose a patient has glaucoma, it will be in a trouble. So you might want to not to do that in cases where you are suspecting patients where you might have a post-operative high pressures, or patients where you don't handle your muscles properly. You might cause muscle damage, causing squints, causing muscle to disrupt. And last but not the least is scleral perforation. So you are driving a car, you know that you are 99.9% safe. It does not mean that you can confidently say that no, I can avoid accident always. So you do get sometimes accidental perforations. Not that that's the end of life or end of world, but you can still manage. So these are all the complications or problems which you can encounter while using a belt, managing the vitreous base. So mind you, this is not doing a scleral buckle where you're going to take this risk to manage the vitreous space. So you have two options of managing the vitreous space. One is putting a belt and removing the bulk of the vitreous and the vitreous base and trying to get the same results out of it. So these are the problems when you do a belt and you have these problems. So you mean to say that vitreous surgery and primary vitreous surgery doesn't have any problems? No, it has its own set of problems. So it's not practically possible sometimes to relieve off all the traction, especially in kids when you can't pull off the PVD completely to the periphery. So what are you going to do? Are you going to shave the whole vitreous right from the posterior to the periphery, which is not practically possible. That's why most of the times when you are children, where you know that it might be difficult for you to get a PVD, we would prefer a belt or prefer a buckle to start with. In case if you still feel that no, this needs a primary vitrectomy, would prefer to put a belt in those cases where you know that the traction which cannot be relieved completely. So the basic idea is to relieve the peripheral traction. And the lens damage, you know that we are showing that depressing the periphery and trying to shave the base. It shows, it looks good, it sounds easy, but sometimes yes, you do cause lens touch, you do cause lens damages, so you need to be careful. So that's a problem which you encounter, and if suppose in a young patient you are going to remove the lens and then you're going to have many problems with his accommodation and all those things. So that's something which you definitely need to worry about, especially in these are fresh retinal detachments, and primary surgery with a vitrectomy are going to get into cataract complication soon. What are the advantages? So as I said, if you have a peripheral vitreous which is not debulked completely, so whenever you start doing a primary vitrectomy, you realize that no, I am not able to see the periphery that well because of some reason or other, there is some scarring, you can't depress well. So there is something which is happening to telling you that no, I am not able to remove off the peripheral vitreous. You know that there is still the vitreous left, which can cause contraction and cause retinal detachment. No point thinking and saying that no, I will not put a belt at all. So you can even remove off all your plugs and cannulas and go ahead and put a belt and then do a surgery. Nothing wrong in it. Do whatever it is needed to get the best results out of it. So don't worry about whether you're putting a belt or not putting a belt. And as I said, children are trauma where it's not, the view is compromised and not easy to trim off all the traction, especially because of incarcerations and many vitreous adhesions. And if you are saying without belt, yeah, so cases where visualization is good, you are able to give a patient a better cosmesis, I would say better visual recovery, faster visual recovery, because you're not going to put a belt, and patient is more comfortable at the end of the surgery or maybe post-operative period, and you get the same results as what you get. So we did a small study, so looking at scleral buckle was a primary vitrectomy. This is how our results were. So these are all simple retinal detachment cases. So if you look at it, there is not much of a statistical difference between the two groups. So means to say that whether you do a buckle or do a vitrectomy, a primary vitrectomy without a belt, in cases of a simple retinal detachments, the results are almost similar. So you need to choose a right case for right patient. So that's what is more important. Thank you.